The dream machine. DICOM, HL7, IHE, and Snap. We're building the future, never looking back.
Hey everybody, welcome back to Imaging Informatics Unplugged. This episode is a little bit different. Rather than the usual format, I'm sharing a webinar session from the Canada Health Infoway Enterprise Imaging webinar series. This topic is on the Pan-Canadian Health Data Content Framework and the development of medical imaging data standards as part of the larger connected care effort in Canada. Sandra, Milicic, and Uyen walk through the framework, the thinking behind the medical imaging module, the standards and consultation work shaping it, and the opportunities for the imaging community to get involved. This is not just some high-level policy talk. The discussion gets into hard stuff like semantic interoperability, terminology alignment, adoption pain, reporting structure, implementation realities, and what it actually takes to create data that can move cleanly across systems and still mean the same thing on the other end. So whether you're in imaging, standards, informatics, or broader digital health strategy, this gives you a useful look at where some of the national conversation is heading. And while you're at it, check out the Canada Health Infoway Enterprise Imaging community. Keep an eye out for future webinars like this. There are some genuinely relevant topics coming up. And with all that said, let's jump into the conversation.
Hey, good afternoon, everyone. Thank you for joining us today. I'm Sandra Milicic. I'm pleased to be here with you and my colleague Uyen. Today, we'll be walking you through the Pan-Canadian Health Data Content Framework with a particular focus on medical imaging data standards. We'll start with a brief overview of the framework, then walk through the development of the medical imaging data standards, and finish with opportunities for your involvement. So the Canadian Institute for Health Information, CIHI, is Canada's national health data organization working with every province and territory to collect, connect, and analyze health data. Canada has an incredibly rich health data asset, but we're not yet fully unlocking its potential. When data is connected and accessible, it enables faster, safer, and more coordinated care. Our role is to ensure that data is trusted, standardized, and usable, and to turn it into insights that drive better decisions across the system. So while better data leads to better decisions, getting that data to be consistent and connected across systems is still a challenge. So the challenge is that Canada's health data is not consistently standardized or connected. Patient information is fragmented across jurisdictions and across multiple systems. The impact of fragmentation is real. People don't always have access to their complete health information, and care becomes harder to coordinate, which can affect both patient safety and experience. It also creates added administrative burden for clinicians and contributes to growing costs across the system. What this slide here shows is that connected care in Canada has moved from concept to coordinated pan-Canadian action. Since 2022, we've seen strong alignment through the introduction of the Pan-Canadian Health Data Strategy, the Shared Interoperability Roadmap, and the Health Data Charter. That's been reinforced by federal legislation like Bill C-72, and more recently, the introduction of Bill S-5, which is aimed at enabling interoperability and reducing data blocking by health IT vendors. This proposed legislation would complement and catalyze the roadmap's vision. CIHI has also released national standards like the Pan-Canadian Health Data Content Framework and the Canadian Core Data for Interoperability, which we often call the CACDI, progressing from draft version 1 introduced in 2024, most recent version of the CACDI, version 2, just recently released in March 2026. Giving us a clear data standards foundation for connected care. So the pieces are increasingly in place, the direction, standards, and legislation, but the challenge and the opportunity is accelerating adoption and turning this into tangible improvements in access, care coordination, and system efficiency. At the foundation of this work is the Pan-Canadian Health Data Content Framework, which is a single comprehensive standard for health data across Canada. You can think of it as a shared data language defining the data elements, value sets, common data architecture, and structures used across systems. It's designed to be person-centered and usable across all jurisdictions and care settings. The goal is simple, which is to improve the quality and consistency of health data so it can better support research, care, and system management. A few key features I'd like to highlight is that it's pan-Canadian and sector agnostic. It's comprehensive across clinical and system uses and includes maturity levels so users understand how ready each component is. It is also fully bilingual to support implementation across the country. So how does this actually help the system? This framework enables one common data standard that supports both primary and secondary uses of data. In practice, that means it supports data across 4 key areas: care for individuals, operations within care organizations, health system planning, and population and public health. The goal is to create a connected data ecosystem where the same high-quality data can flow and be used across all these levels. This is also a shift for CIHI, moving from primarily collecting data to enabling data to be more used directly in care and decision-making. And importantly, this approach is technology agnostic. The standard provides the shared structure that allows data to move and be understood across systems, similar to how medical imaging works today. This becomes even more critical as we look to AI and advanced analytics because the quality of the outputs depends entirely on the quality and consistency of the data underneath. But to get there, we have to deal with a fundamental change. So standards are like toothbrushes. Everybody wants one, but nobody wants to use anybody else's. And that's exactly what we see across the health systems. Every EMR has its own way of defining and structuring data, its own, would you say, data dictionary, and those don't easily align or get shared. So that's what the fragmentation problem is. And what we're doing instead is building on existing standards to create a shared data language, not replacing systems, but enabling them to speak the same language so that data can move and be understood across settings. So how are we building this? It's grounded in a co-design approach. It brings together patients, clinicians, governments, vendors, and partners to actively build the framework with us. We prioritize content based on real health system needs with a strong focus on patient safety. And also, we're not starting from scratch. We deliberately build on existing Canadian and international standards. And importantly, the process is open and iterative. It is part of an ongoing cycle. We release content, gather feedback broadly, and continuously refine to ensure that the framework stays practical, credible, and aligned with how care is actually delivered. Our publishing cycle is predictable and repeatable. Draft products are released in September, followed by a 60-day open review period, and the final version of the CIHI is published in March. This cycle gives stakeholders time to review, provide feedback, and prepare for adoption. There is a breadth of products that make up the framework and the CIHI. On the left-hand side of this slide is the full set of products that support the standard and its implementation. On the right, the CIHI focuses that into a core data set for interoperability. Together, these products are not just the data content standard itself, but the full set of supporting products needed to understand, implement, and use the standard. So this slide shows what the framework looks like in practice. It's made up of standardized data categories, with each block representing a building block of health information. We started with version 1 in 2024, which are the teal blocks, expanded in version 2, which are the green blocks, and we're currently working on version 3, which are the orange blocks. And we'll continue to build out additional categories over time, which are kind of the grayish blocks. And one of the areas we're actively developing now is medical imaging. So earlier I mentioned that the toothbrush problem. Everyone has their own approach. In imaging, DICOM solved that, not by forcing a single system, but by establishing a shared standard that everyone could follow. The simplest way to think about it is we're trying to do for the rest of health data what DICOM did for radiology. Before DICOM, imaging was fragmented and it was vendor specific. But after DICOM, we had a standardized structure, shared meaning, and true interoperability. DICOM and the Pan-Canadian framework are complementary. One does not replace the other. DICOM enables imaging exchange, while the framework focuses on a person's health data across the system. So we're not replacing DICOM. We're taking the same approach it used to transform imaging and apply it more broadly. And applying it more broadly. And with that, I'll hand it over to Uyen to walk through the medical imaging data standard.
Okay, so up next, the next portion of the presentation, I'll be sharing some of the development work that we have done on the medical imaging content in the framework so far. So first up is the scope of the medical imaging data content in the framework. So we are aligning with the International Patient Summary Standard definition of medical imaging, which defines it as the production of visual representations of body parts, tissues, or organs for use in clinical diagnosis. And these include modalities like X-ray, MRI, single photon emission tomography, PET scans, and ultrasound. This is a starting point. It's a foundation for us that we can continue to build on over the next release. What we have done here is break the imaging workflow into 3 parts: the medical imaging orders or service requests, medical imaging investigation, and medical imaging diagnostic report. You're probably wondering what the blue versus the green parts are. So one point of clarification is service request is a broader shared category in the framework. The service request category is intended to support requests across different types of services, which includes medical imaging, but also lab and other clinical services. So while the medical imaging service request is part of the overall scope that you see here, our main focus for this presentation, as well as our development work, is on imaging specific content, so the investigation part and the diagnostic report of the study. In the service request section, some of the key elements that we aim to capture include request status, requested modality, the request investigation, urgency, request date and time, and the provider who made the request. For medical imaging investigation, these include elements such as study status, the perform modality, the perform protocol, body site laterality, whether contrast is used or not, etc. And then lastly, in the diagnostic report section, we have elements that include the report status, whether the interpretation is preliminary or final, the narrative report itself from the study, comparison with prior images, and communication of critical findings. Here, we summarize the standards and references we reviewed to develop the imaging content for the framework. We acknowledge that we are building on a great deal of existing work that has already been done in the medical imaging interoperability space. So a perspective that we took when approaching the development of this content is to acknowledge that there are different layers of interoperability that is involved in exchanging medical imaging information. So for imaging communication and data exchange standards, we reviewed specs including DICOM, CIHI radiology, and HL7 FHIR, as these are established foundation already used across environments. Complementing that, we also reviewed USCDI, IPS, PSTA profiles, to help ensure consistent representation of clinical content for cross-system exchange. We also looked at provincial imaging standards, as well as Canadian implementation references to better understand the regional differences and identify profiles that are already been implemented. And in addition, we have also received feedback from Ontario Health medical imaging standards work, and we are closely following their updates and revisions to assess our alignment with their work as it evolves. And for terminology development, we are leveraging SNOMED CT CA to support coding of clinical concepts such as body site laterality, investigation performed, etc., where appropriate. So the overall intent here is to reuse what already exists and leverage from existing standards whenever possible, so that interoperability is strengthened across systems rather than recreating things from scratch. Our data and terminology development approach is intended to be consistent with the broader framework approach. And by that, we mean reusing existing national and international standards as much as possible, but also making sure that the Canadian context is reflected. So our approach is to first ask whether an established terminology standard already exists for a given concept, for example, and then we assess whether that standard is appropriate for the Canadian context and for the specific imaging use cases. If there are any issues or gaps, we bring these forward for review with expert working group for discussion. So this work is also being developed collaboratively with Canada Health Infoway, given their role in maintaining SNOMED CT, the Canadian edition, as well as the Canadian extension of FLOINC, and their role in supporting terminology request and translation as well. Here, we wanted to show a snippet or a practical view of how the medical imaging content appears in the data content standard. So in the DCS table, imaging content is described using details such as data elements, definition, the recommended value set, as well as listing out some example codes from the value set. The blue rows, which we have here with an asterisk, represent front-end data. So this means that the information is more likely to be entered by the clinician, selected, or viewed directly in their clinical system. White rows represent back-end data, and these may be system-generated or derived from other data elements. And then elements marked as essential are those identified as part of the CACDI that Sandra had mentioned before. The framework also uses a maturity model to show how far along the development for a data element or value set is. So future development would mean that a concept has been recognized, but it has not yet been developed. Level 0 means it is in development, but it's still a work in progress. And so these would include medical imaging data elements that we are publishing as part of version 3 of the framework this fall. And then from there on, the content moves through increasing levels of review and stability. So level 1 is draft, where expert input has started to be incorporated. Level 2 is where the concept is proposed, meaning it has gone through at least one round of open public review, I should say. And level 3 is where it's ready for use, so meaning it's considered ready for implementation. Here we have some links to some of the Pan-Canadian framework products that Sandra has previously mentioned, and also links to version 2 of the CIHI that was just released. So this work is underway and it's planned to be published as part of the version 3 draft release of the framework in September for open review. And the open review period typically runs every year from October to November. But before we publish this to the wider audience, we are hoping to engage subject matter experts who can participate in an earlier look at the content if you are willing, as this early review would really help us and give us a chance to refine some of the definitions, terminology choices, as well as content structure before the draft goes out. So if this work is relevant to you, or if you know others in your organization who would be interested in contributing, please reach out to us at connectedcare@cihi.ca. We would welcome the opportunity to coordinate any follow-up discussions and involve you in this work. And I believe that concludes our presentation. If you would like more information on the Connected Care project at CIHI, or if you'd like to reach out, our info is here. And I just want to also mention that we are also joined by some of our wonderful colleagues from CIHI, from the clinical and terminology team, who may be interested in joining the discussion following this presentation. All right, I guess that's back to you, Jason.
Okay, just trying to find the unmute button, and here we go. Yeah, thank you very much. Really appreciate you taking the time today to go through this with us. You have alluded to it, and we'll see if any questions come in. We haven't received any yet, but I think maybe it's worth just asking the impetus for starting this. You touched on this a bit. I'm just curious as far as, the need. Where did this start? What was the impetus that drew you to start building out this framework? Either of you? Yeah, Phil.
I can take this on. It started in 2022 with the roadmap and working just to get myself. So the Pan-Canadian Health Data Strategy, the shared interoperability roadmap, and then the Health Data Charter. So in 2022, the Pan-Canadian Health Data Strategy was introduced, and CIHI started working with other organizations across the country, or how would I say, in order to establish the Pan-Canadian Health Data Strategies. It was through that vision to start working. So the framework was established. So I'll call on my other CIHI employees if they have anything else to add.
I can chime in too. My name's Ali. I'm a program lead on the Connected Care team with CIHI, working with Uyen and Sandra. And a lot of the impetus for the standards are, around patient safety also, and patient access to their own health records, and also the access of health records to other providers across different jurisdictions where you would need access to someone's data, even if you're talking about a different province, like if they broke their leg or something and they needed access to their images across a border or sector, then we do need some national standards that underpin the sharing of that information to make sure that it's accessible to patients and providers at the point of care. There's other factors in terms of health system performance management as well that feed into this, but yeah, putting the patient kind of at the center of all of this, and providers, and making sure you have access to data in near real time and not having to constantly go elsewhere in other places to access the information, because we know a lot of, early days like the PACS are on a different system than where the patient chart is and that kind of thing. So we need to pull these things together.
Thank you. Thank you very much. We have a couple questions in the chat, and Kevin O'Donnell, I'll summarize it a bit, but it speaks to We have semantic interoperability, which can be a challenge, not for lack of standards, but on the adoption side. And he references the Radlex playbook is a candidate code, which has been folded into LOINC. There were some efforts from HIMSS and SIM that did an assessment on the best ontology to use for enterprise imaging. I'm curious in what Kevin's asking here is, have you looked at that? And do you have thoughts on helping hospitals through the cumbersome migration process, since these codes are in the ordering system, the modality, the packs, so they kind of exist everywhere for different purposes? Your thoughts on this?
I can take this one. Yeah, this is a great question. And we have looked at the LOINC RSNA playbook, and it is a very important in the imaging terminology landscape, especially for procedure naming and cataloging. But for this framework, our aim is to support broader semantic interoperability across systems and use cases. And for that, our current terminology approach is to leverage SNOMED CT for clinical meaningful concepts such as imaging procedure, and to align it with other the terminology that we are using for body site laterality, etc. So that's why we are still aligning with established imaging standards like DICOM, but also trying to support semantic interoperability across the framework.
And I think it's worth mentioning. I referenced to him work. They landed on SNOMED CT as well, so it's a very well established for outside of radiology and making sure you can capture that semantic interoperability. Going a little further on what Kevin's question is around the adoption side. So now that you've nailed down what the ontology is that you're using, have you thought around what are the adoption challenges and the steps that you might be taking in order to help hospitals and organizations change from one existing code system to an approved set that you're recommending?
Sure, I can jump in on that one. So this is definitely a challenge, and we appreciate that. One of the problems that we are looking to solve is that we know that there's a varied state of data standards and terminology adoption across Canada right now. So there is a lot of work that is going to be happening to think through really what is needed for implementation and how CIHI may be able to help with that. So it is on our radar. We don't have all the answers at this point, but is part of the work to come, and part of these ongoing consultations to understand, again, what supports are needed and how CIHI can help with this.
Thank you. Dave, you have your hand up. Feel free to chime in and either ask a question or piggyback on that.
No, I'm going to comment on what Kevin has brought up as well, but I'm also going to introduce it from two different perspectives. One is how we approach interoperability today is the majority of it is actually using interfaces and mapping. You have to realize that process is very time consuming and resource intensive if we actually apply good governance to it. And in my experience, when you go to the provider systems, especially in Canada, our governance around maintaining imaging, RAS, or whatever system you have, dictionaries, and keeping them up to date and deprecating the ones that you don't use, it's the last thing healthcare providers think about, because they're thinking about just getting the patient volume through and taking care of patients. And if it isn't broken, if there's a deprecated study or code or description, it doesn't really impact patient management. From the other side, that's from the provider side. If you get to the vendor side would love to have better governance, because whenever they bring in either an upgrade, system upgrade, a big one, significant, it's literally a new system, or they're switching tax vendors or whatever, or linking up to a DIR or whatever, then all of a sudden the dictionaries and mapping come to the forefront. And if you don't have a well-governed dictionary, and not only that, the definition of the data elements that make up that dictionary, it's very time consuming, and the cleanup is huge. Anybody that's gone through a migration can attest to that. What this offers is now a little bit more light at the end of the tunnel. If we can standardize to a national standard in defining semantically what these descriptions are, the concepts, and we need a lot of collaboration on this. And I think this is what Sandra and Uyen are asking. We all are experts in our own field, different people here, quite a few imaging people, a lot of terminology, health terminology people. We need to work on this together, because as a person from the imaging background, we're very well educated on what a study description or a need for study is. And we have our own kind of linguistics around it. But at the same time, we never think about what is the information model that it fits into in order to make it usable going forward, especially machine usable. And that's what leads us to the AI part of this. AI will never be as effective as we think it will be unless we clean up the input going in. It comes back to that garbage in, garbage out again. So one of the things we need to clean up is to have some type of overall definition. Now we cannot go to every jurisdiction healthcare provider and code everything for them or define everything. But let's start at the high level. And I think that's the good part of the plan that CIHI has come up with. They're going to start at, they're going to handle that 65% is easy, let's say. And then there's always that 35, 25% as you get into implementation. That's hard. And we'll deal with that later. Sorry, I'm on a soapbox. I'll turn it back over. There's other questions.
Thanks, Dave. So there's a question from Thomas O. Could you please provide rationale for selecting IPS as the representation?
I can jump in on that one too. So great question. So for us, our goal is to align again as much as possible to existing standards, and IPS is certainly a guiding international standard in many areas beyond medical imaging as well. We also know that within Canada, many jurisdictions are developing their own derivative of a patient summary. And so this is one of many standards used as a guiding source. So Uyen provided an overview of different specifications that were used to align to. In terms of the reference to the ISO IPS, that is really about defining our scope for what we consider medical imaging. I know even through this group, there's lots of different definitions for what is diagnostic imaging, enterprise imaging, medical imaging. So for us, as a starting scope, we are aligning to the international patient summary scope for medical imaging, again, at least as a starting point. And then the framework is iteratively developed, so it can be built out from there.
Perfect. Thank you very much. And another question from Kevin, going a little further. So given your view to improve both individual patient care, but also system-wide care, have you looked into BI-RADS, LI-RADS, PI-RADS, and do you have the ambitions to help with the outcome data collection that feeds back into the periodic BI-RADS revision process to improve the code criteria for better patient outcomes? So with this project, Canada might have a more coordinated national data space than elsewhere.
Great question. So that one, I do admit, is less familiar to me. So Kevin, if you'd like to reach out following the session, love to hear more about that and how we might be able to address that, but interested to learn more about your thoughts on that. So please do connect with us after the session, connectedcare@cihi.ca, and we can talk more on that.
Likewise, yeah, I'm not too familiar with this either, so would love to look more into it. So please share with us your sources.
Okay, well, David Kwan has his hand up. Go ahead, Dave.
Kevin, please chime in. I don't want to speak for you, but based on Uyen's. So the radiology diagnostic systems from the ACR, they're actually developed by clinical specialists, radiologists that are the forefront of their field. And Kevin's suggested BI-RADS here. There's others like TI-RADS, which is thyroid nodules using ultrasound. And one big one is I forget which one it is. It's around colorectal cancer, which is making the big news today in Canada. It's the second largest cancer in terms of fatalities in Canada. These, we call them diagnostic systems, but really it's a structured report. And the structured report has all these pull down menus with all these defined concepts, everything from description. And in the end, they also have patient management elements that come out of it, and that feeds directly into patient follow-up. So Kevin is a really good suggestion for you guys to have a really big look into this, because just because it's an American College of Radiology that defines this, you're going to find during my work at Cancer Care Ontario, we always look to these artifacts to guide what we wanted to do in Ontario around cancer detection and screening. So it defines everything. And not only that, I think a lot of the stuff that you're going to find in there has been mapped to terminology, especially RADLEX and LOINC. So it's worth investigating this. I just want to make sure that this is followed up, whether it's with Kevin or ACR.
Sounds great. Thanks for the suggestion. I also did want to add that as part of our consultation process, we have also been working with the Canadian Association of Radiologists. So we do have some feedback from them as well. So again, if there are any other people from this group today who have capacity and interest in providing us an early review on this content, we'd be happy to work with you. We are trying to reach a broad audience and make sure that these standards do reflect the pan-Canadian landscape.
And Kevin, I see that you have unmuted yourself. Feel free to chime in if you have further to color to add on this.
Sure. Just to supplement what Dave was saying, I love the presentation, love the project, and it really, what they're trying to do with BIRADS is essentially protocolize one piece of medicine. And the idea is normally you get an imaging report and the radiologist says blah, 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 blah in, 1,000 different ways. And then the clinician reads the blah, blah, blah and interprets it, and has 200 different variations on what they choose to do next. And so they decided to start with mammography and breast imaging, which is the BI in BIRADS, and say, okay, look, there's basically 5 scenarios. That's the outcome of a screening breast exam. And everything is going to be a flavor of one of those 5 scenarios. And so, it could be, yep, everything's fine, come back in a year. At the other end, it could be, full-blown cancer. We need to get into oncology consultations. And then a number of the middle ground flavors. And so they worked for a number of years, and they basically came up with these BIRADS codes, BIRADS 1, BIRADS 2, and each of them have criteria for when the radiologist assigns them. So if you see calcifications like this, or masses like that, greater than 2 centimeters, less than 2 centimeters, they put together all these criteria to come up with these codes. And then on the clinician's end, if it's a BIRADS 2, your recommended course to proceed with is, order a biopsy and, et cetera, et cetera. So they've really kind of protocolized it. And the premise is that over time, you could come back and look at outcomes and see, based on the outcomes we're seeing, we're doing way too many unnecessary biopsies. So maybe we should throttle back a little bit on the criteria on this BIRADS code. And so one hospital could go through and do the experiment for a couple of years and find out that, yes, they decreased unnecessary biopsies and there was no increase in, mortality rate or diagnostic accuracy, at which point they then upgrade the whole system and everybody else adopts that. So it's sort of an engineering process improvement approach. And that would work great if you had a national data health system in place so you could collect all of those outcomes information, which most countries don't have. And so this work that you're proposing here within the Canadian space, I think would be tailor-made to align with that sort of activity. Their hope is they've done it with BIRADS is most widely adopted, but as David was describing, they're also looking on it for lung cancer screening and prostate screening and liver and many of the rest. But yeah, the project at CIHI could be a lovely fit for that.
Thank you. Thank you so much for your support and your recommendation. And it's going to help us really build a strong foundation. Just to start off and continue to reiterate our data standard along the way. So thank you so much.
And I see Thomas has his hand up. So Thomas, feel free to unmute yourself and ask your question.
Yeah, actually, first, I would say based on my very limited understanding about the DI sector, I believe there's more focus on the terminology side. But since I've been with IPS, for a long time, starting 2019, I just want to bring some understanding about this piece of very my understanding about APS actually well known here is the document based. It's a composed summary with curated information. That's meant my understanding about the 2 features of this IPS, which has comes out we know that from the ISO IPS, the logic data model. And on the other side, I do not have a very good understanding about this, what we're talking about medical imaging right now. And I'm not sure this is a report focused or document focused in that matter. But at the bottom lines here, I hope that this medical image project could run well without any possible constraint, which is coming from the IPS that I call it architecture I use the word maybe not proper constraint from that matter. And also, I would say, since we do have a CIHI under development within Canada, I'm not sure we consider to collaborate with CIHI to see if there's any possibility to encourage. I mean that from FHIR perspective, thematic imaging work align with the CIHI FHIR implementation work. Just stop here.
Kevin, do you want to wade into this with your IDR work at all? I don't mean to put you on the spot, but we've been on the CIHI radiology side, we've been trying to deal with, how can we say, breaking up the narrative text in radiology reporting. And Kevin and a few others have been instrumental in moving this towards the FHIR model. That's the first thing. I cannot speak to the constraints on IPS around this, and I'm not familiar with what CIHI wants to leverage from IPS in terms of the architecture around the Pan-Canadian framework. In terms of, I think a lot of us have been working on trying to free up the information that is contained in an imaging report. Basically, historically, it's been an HL7 version 2 text plot. And, because of that, it's kind of constrained us what we wanted to do in terms of mining information as well as a workflow. And Kevin has been working away at coming out with the imaging diagnostic report based on FHIR resources. And something will be coming out soon, phase 2, let's put it that way, which is more tackling really the hardest part, which are the findings part of a narrative report. People that are familiar with imaging will know what that is. For the terminology side of things, there's a lot of data in the findings. The challenge for Kevin and the group is a lot of it is meaningful information for radiology, and some of it is significant for the stakeholders that use an imaging report. And that's been probably one of our biggest challenges. I don't want to speak for Kevin. I don't know if you want to make comments on that part. I'm only answering sort of addressing Thomas's part of his question.
Just to what you'd asked, I think I can remember Sandra Uyen had the picture with the 3 boxes for kind of the order, the study/procedure, and then the report. And those are kind of in order of maturity. The order, we've got pretty established orders with V2 messaging, and even though it's a clunky old standard, it basically works. We have a relatively mature FHIR object for the service request, and so it's pretty clear what we're going to do next and what that'll look like. So that's kind of a nicely stable space. The imaging study, well, we've got DICOM for the images. We have the imaging study resource and the procedure resource to capture what was done and what data was produced. So the imaging study resource is a little newer than the service request. So it's not quite as mature-ish, but it's pretty close. Once we get into the report itself, as David points out, the old stuff is text blobs stuffed into V2 messages or PDFs, or we've never had a great encoding. HL7 defined the CDA, the clinical document architecture. We defined how to translate an entire radiology report into that. Healthcare didn't really pick up on CDA. So now they're doing it again with FHIR. And so we're still, and as David says, we're meeting next week in Oak Brook for a week as CIHI Radiology to work on the imaging diagnostic report, profiling of the FHIR diagnostic report object and all of the embedded observations. So we're on our way there, but the ink isn't yet dry. It's not even fully on the page. So that's one that we can't really get people to adopt that for another couple of years until we've test driven it. So we're kind of stuck with blobs of text, which is a little sad.
This has been a great conversation. I really appreciate the slides. I think that there's an opportunity that we'll probably be bringing you back in a couple years, and we'd like to revisit and see how the maturity and the implementation of this goes. But we wish you all the best. We're very excited to see anything that's going to improve interoperability. And I'm looking at the clock here where it looks like we're winding down. There's not many new questions coming in here. So unless I see something new coming in, I think we can call it a day on this presentation. Again, really appreciate the hard work from the presenters today and the hard work from the CIHI team on all you've done. Thank you.
Be the dream machine. DICOM, HL7, IHE, and SNAP. We're building the future, never looking back.